Acute coronary syndrome occurs when an atherosclerotic plaque inside a coronary artery that supplies blood to the heart ruptures with the formation of a thrombus on its surface. 90% of cases are caused by atherosclerosis, making it the most frequent cause. It is important first of all to evaluate all other cardiovascular risk factors, both non-modifiable and modifiable. A family history of early cardiovascular events, as well as age, over 15 for men and over 16 for women, are non-modifiable factors. Smoking, diabetes, hypertension, dyslipidemia, and obesity are all modifiable variables. They can be managed with medication or exercise. ST segment elevation myocardial infarction, or STEMI, and non-STEMI are two forms of occlusions in acute coronary syndrome. A total blockage of the coronary artery suggests a STEMI, which needs immediate coronary revascularization. On the other hand, NSTEMI represent an incomplete occlusion and requires risk classifications. We'll concentrate on ST segment elevation in this video. Non-ST will be discussed separately in another one. It is very important to remember that ST segment elevation is a medical emergency with a life-threatening situation. The diagnosis of ST segment elevation is characterized by the presence of a typical chest pain, which is abrupt in onset and often occurs at rest. This pain is retrosternal, constrictive in nature, and may radiate to the left arm and jaw, and can last for more than 30 minutes. Nitroglycerin, a vasodilator medication, usually does not reveal its intensity. Sweating, nervousness, or a sense of impending doom are possible associated symptoms. In women and elderly patients and those with diabetes are more likely to have atypical symptoms, which may mimic other medical conditions. In this case, we may see signs like burning epigastric pain, difficulty breathing, and some unusual symptoms. It is important to be cautious, as myocardial infarction can be silent in some diabetic patients. During your clinical examination, it is important to evaluate the patient's vital signs and their general condition. This includes neurological evaluation using the GCS or Glasgow Coma Scale, hemodynamic evaluation by measuring the blood pressure and the heart rate, and a respiratory assessment focusing on a respiratory rate. Further tests that should be carried out include a 12-lead ECG, which can reveal positive and symmetrical T waves initially, and the ST segment elevation above the baseline, greater than 1 mm in the peripheral leads, leads 1, 2, 3, VF, VR, VF, and greater than 2 mm in the pericardial leads, V1 to V6. We will discuss the ECG and how to interpret it in another video. Starting in 6 hours, there is a Q wave development secondary to myocardial necrosis, followed by a T wave inversion after 24 hours. When complications are suspected or when there is a contradiction between clinical symptoms and the ECG results, immediate echocardiography should be done. Additionally, the diagnosis can be guided by the measurement of high sensitivity troponin levels, which can identify myocardial infarction as early as 3 hours after the beginning of the chest pain. Keep in mind that you should not delay waiting for test results before initiating the necessary treatment, because the patient's life could be in danger. ST segment elevation can result in a variety of complications, ranging from rhythm and conduction complications to hemodynamic issues like acute heart failure, as well as mechanical problems like post-infarction septal rupture, which is a catastrophic event with a serious prognostic consequences, and acute mitral regurgitation, where the mitral valve in the heart does not close properly, leading to the backward flow of blood from left ventricle to the left atrium during systole. Additional complications could be thromboembolic or infectious. We'll talk about each pathology in a separate video. Thanks for watching, and I'll see you in the next one.